Good evening, students. Hope I'm audible. Good evening, everyone. Let me just check the audio video, then we'll start off. Good evening, everybody. Can you hear me? Just I'm checking the audio. After that, we'll start. Hope I'm audible. Good evening, everybody. Okay, perfect. So everything is clear. Let's start the session. So in this session of biochemistry, we'll be dealing with all the important concepts which have been previously asked and which can be possibly asked again and again. Okay. So with that much being said, so the plan of the biochem session in this for today's plan, it's very simple, sir. We have chosen some topics to teach you. Along with that, I will be going in the order what you study. Like आप लोगों ने कैसे तैयारी करोगे उसी order पे I am trying to discuss them. Okay, so let's start off with the first most important topic, that is carbohydrate. So carbohydrates is a star topic of biochemistry. Remember, always it has been asked very frequently. So all the carbohydrates are your sugars, so which are responsible for what? Responsible for one of the major function of carbohydrate is to provide the instant source of energy. They are the instant energy source. Okay, so if they are the instant energy source, my dear students, so what is the classification? How do we classify the carbohydrate? Carbohydrates are classified based upon their ability to get hydrolyzed. For example, let's take a carbohydrate. For example, let's take lactulose. There is a carbohydrate, lactulose. So lactulose, if I hydrolyze it, I will get two other carbohydrates, such as, for example, your galactose and your fructose. Okay. Now, if I break the fructose, will I get any carbohydrate? No, I will not get any carbohydrate. Rather, pyruvate I will get. What do I get? Pyruvate. So, what I'm trying to tell you, any sugar which cannot be hydrolyzed further. So, pyruvate is not a carbohydrate. If pyruvate is not a carbohydrate, means it cannot be what is that? It cannot be a carbohydrate. That means fructose is not breaking into any carbohydrate further. So if any substance which cannot break down into further carbohydrate, I will call it as a monosaccharides. Monosaccharides are the carbohydrates which cannot be hydrolyzed. The examples we have are your fructose. Okay, and also, my dear students, we have glucose, and also you have your galactose. So these are the examples for monosaccharides. Then we have disaccharide. Disaccharide is nothing but when I hydrolyze, means when I break it, I will get how many monosaccharides? I'll get two monosaccharides. Oligosaccharides is up to 9. So if it is more than 10, more than or equal to 10 carbohydrates, if the monosaccharides are present, then I'll call it as a polysaccharide. All of you know the classification. So polysaccharide is the important concept, sir. So polysaccharides are further classified into two types, homoglycan and heteroglycan. So homoglycan and heteroglycan. Homoglycan means throughout the polysaccharide, it is made out of same type of what is that? Monosaccharide. If it is made out of same type of monosaccharide, then I will call it as a homoglycan. The classic example is glycogen. Glycogen is present in the body. It is a storage form of glucose. It is made out of what is that? Glucose. Glycogen is made of what is that? Made of glucose. No other carbohydrate will be there. If same carbohydrate is there, then I'll call it as what is that? Homoglycan. When I'm speaking of heteroglycan is such a substances which are made out of different types of sugars. So we have glycosaminoglycans. The classic examples are glycosaminoglycans, and one more we have, that is your cellulose. So glycosaminoglycans are also called as mucopolysaccharides. Okay. So now, related to mucopolysaccharides are digested by your lysosome. Digested by, yes, lysosomes. Lysosomes. Okay. Lysosomes. So if there is a defect, what will happen, sir? If there is a defect, it will lead to accumulation of glycosaminoglycans. Because glycosaminoglycans cannot be digested because of the genetic defect, leading to two diseases called as Hunter and Hurler disease. Hunter disease and also called as Hurler disease. Okay, Hunter and Hurler disease. There are two diseases in which what is deposited. The question they're going to ask, in the Hunter disease, which substance are deposited? There is a lysosomal defect because of which what is there, sir? There is an accumulation of glycosaminoglycans called as Hunter and Hurler disease. So we have some classic examples of your glycosaminoglycans in the body. So we need to know the location of those glycosaminoglycans. That is your hyaluronic acid. Hyaluronic acid is located in your synovial fluid. Is located in your synovial fluid. So in the joint space, we have a synovial fluid. Synovial fluid consists of hyaluronic acid. Which acid, sir? Hyaluronic acid. This is a very important point to be remembered. Okay. Then we have one more substance, chondroitin sulfase, that is present in your cartilage, my dear students. Where is it present? Cartilages. In the cartilages, we have what is that? We have your chondroitin sulfate. Then we have our keratin sulfate. Keratin sulfate is present in the hair and in the nail. So the hair and nail, are they having same consistency or different densities? Hair is little bit softer compared to that of what is that? Nail. So nail consists of something called as which keratin? Hard keratin. What is that? Hard keratin. So hard keratin versus soft keratin. If you want to understand, hard keratin has more number of disulfide bond. Hard keratin has what? More number of disulfide bond. Soft keratin has a lesser number of disulfide bonds. So based on the disulfide bonds, we can decide the keratin into soft versus hard keratin. Okay. Then we have heparin. Heparin is produced from your one important cell called as mast cells. What are those called as? Mast cells. Heparin is produced by which cell? Mast cells. Okay. So these locations they can ask you, and the classic examples for the glycosaminoglycans also possible. Okay. Let's get into the next one, that is your dietary fibers. So dietary fibers are the complex sugars. They are the complex sugar. Whenever you take the dietary fiber, they are not digested in the intestine or not absorbed by the intestine. So they will go into the body. They do their action, but they will not be absorbed. So this is a very important point to be remembered. Not digested by body, not absorbed by the body. So what exactly they do? They increase the bulk of the stool. So if they increase the bulk of the stool, automatically patient will be able to defecate easily. So it prevents the constipation and also reduce the risk of colon cancer. Okay, so high fiber diet. This was a previously asked question, PYQ. High fiber diet helps in which of the following? Helps in the reduction of risk of colon cancer. Helps in the reduction of the colon cancer risk. We have examples such as lignin versus pectin. Lignin and pectin. Okay. Then let's talk about the glucose transporter. So glucose transporters are also very, very important. Let's talk about the glucose transporter. Glucose transporters usually, my dear students, they're which type of transporter? They're active transporter, a passive transporter. Remember, they're a passive transporter. They work with a mechanism called as facilitated diffusion. Okay, so now when we are speaking of facilitated diffusion, so now we need to understand about some important concept. What is that? These facilitated diffusion, how do they work, where they are located? These are very commonly asked question. This has been asked so many times. I don't want you people to make any mistake here. So let me explain about the glucose transporter. Let's get in little bit into the depth of it. So let's understand the glucose transporter here. So we have first glucose transport, that is only your GLUT1. Okay. So GLU stands for glucose, T stands for transporter. So this GLUT1, my dear students, whenever we are looking at it, this is a very, very simplified concept. It is active all the time. That means active even during the hypoglycemia. Even during which time? Even during hypoglycemia. Even during which one? Hypoglycemia. This is a very important concept to be remembered, because if your blood sugar level goes down also doesn't matter. This glucose transporter will remain active. So it is responsible for the providing of glucose to the vital organs such as your, for example, brain. Okay, so brain will be receiving the glucose. Even if blood glucose level goes down, continuously it will be receiving the glucose. And also your red blood cells, and also the placenta, So these are the locations where GLUT1 is majorly located. So this is physiologically. Now pathologically, where they are located? in which disease we can find. So pathologically, where you can find the glucose transporter 1 here, the glucose transporter 1 can be found pathologically on one location, that is your tumors. Which one? Tumor cells. So tumor cells also take up all the glucose very quickly and rapidly with the help of this transporter, only glucose transporter. Okay, let's go to the next one, GLUT2. Now GLUT2 is located where? So GLUT2, my dear students, this is located one main location, that is your beta cell of the pancreas. Which cell of the pancreas? Beta cell of the pancreas. If they are located on the beta cell of the pancreas, what do? Their function, again, it's a very important, because there is one confusing point, whether the glucose transporter dependent upon the, yes, dependent upon your, what is that? Dependent upon your insulin or not, that will come. That's why I'm telling you again and again. So beta cell of the pancreas, it is there. So once if at all glucose transporter 2 is there, so glucose transporter 2 take up the glucose, okay, into beta cell, glucose into beta cell, and do what? And it will cause the release of the insulin. This is a key point to be remembered. It causes the release of insulin. So the question comes to us is, insulin is released with the help of which glucose transporter? Insulin release will occur with the help of glucose transporter 2. GLUT2. So GLUT2 is responsible for what? Release of insulin. Remember, it is not dependent on insulin. It causes the release of insulin. This is a very important point to be remembered, dear students. Okay. Now, if at all it is causing the release of the insulin, so where it should be located? Of course, beta cell. That is why after having the meal, blood glucose level will be increased. After having the meal, blood glucose level increase. So GLUT2 will become more active. As GLUT2 becomes more active, there is more release of insulin. So that is why immediately after having the meal, everyone will tell insulin release will occur. Why insulin release occur? Because it is activating the glucose transporter 2. Then you have a GLUT3. Now your GLUT3, dear students, it's located where? Yes, very importantly, where is it located? It is located in the neurons. It's located in the neurons. Okay. Now GLUT4 is very important. That is only your insulin dependent glucose transporter, GLUT4. So GLUT4, my dear students, it is dependent on the insulin. It is a insulin dependent, means to activate the glucose transporter 4, we need to have, what is that? Insulin will act upon the GLUT4. So basically, when insulin receptors are activated, GLUT4 becomes active. Okay, so if insulin is not there, no activation of the insulin receptor. If there is no activation of the insulin receptor, no action of your glucose transporter 4. So this is a very important. They have asked the location previously. It is located in the muscles, in all your skeletal muscles, in your adipose tissue, in your, what is that? Adipose tissue, and also they are located in your very important location, that is your liver. So for the glucose to enter into the muscles, adipose tissue, liver, and even to the heart, which transporter is required? GLUT4 is required. GLUT4 is action dependent on insulin. If insulin is not there, GLUT4 will not work. So they will ask you, which of the following glucose transporter is insulin dependent? So insulin dependent one is which one? Glucose transporter 4. Bacho, which one? Glucose transporter 4. So this is a very important previously asked question. In last exam also they had asked this question. GLUT4 is located where? A simple straightforward question, no mistakes to be done here. Then we have our glucose transporter 5. Okay, so glucose transporter 5, actually it will not absorb the glucose, sir. It will not absorb the glucose, rather it will absorb something else. It absorbs the fructose. It absorbs which substance? Fructose. It absorbs which substance? Fructose. It absorbs the fructose. It is located in two locations. One is your intestine. Which part of the intestine? Of course, your small intestine. And also, my dear students, it is located in the sperm cells. Okay. So, sperm consists of which glucose transporter? Glucose transporter 5. Okay. Now, once we understood about this glucose transporter, let's go into the next important point. What is that? That is your, yes, GLUT 1, 2, 3, 4 we discussed. Then we have secondary active transporter for the glucose. So the secondary active transporter for the glucose is called as SGLT. So it is a sodium glucose transporter. Sodium glucose transporter called as SGLT. It's a type of, it works with the help of which mechanism? It is a secondary active transport, means for it to work, it requires two things together. It requires sodium also and glucose also. If you have only glucose, this transporter will not work. If you have only sodium, it will not work. It requires both the, what is that, sodium and glucose, both of them are required. So sodium and glucose will be absorbed together with the help of sodium glucose transporter. It is located, SGLT1 is located in the small intestine, and SGLT2 is located in the large intestine. So for example, whenever we have ORS, oral rehydration solution, whenever we are giving, so ORS basically rapidly absorbed, because of what? ORS consists of two things. Two major constants of the ORS are your glucose and your sodium. So ORS will be rapidly absorbed because of this SGLT1 transporter, which is located in the intestine. And when we are looking at the SGLT2 in the kidneys, so in the kidneys, anybody can tell. I want you to be very specific. They are located in the proximal convoluted tubule. So in the PCT, if at all, if you activate SGLT2, they will cause the reabsorption of what? Reabsorption of, yes, of your sodium and glucose. Just let me tell you people, so what is happening in the PCT? It is reabsorbing the sodium and glucose. If I block this SGLT2, now sodium is not reabsorbed and glucose also not reabsorbed. So glucose will go into the urine, causing the reduction of the blood glucose. So that is why in pharmacology you would have read SGLT2 blockers are used for the treatment of diabetes mellitus. Why we are using it for the treatment of diabetes mellitus? Because it will reduce the blood glucose by making the glucose to go in the urine. Okay, so this is the location you need to understand. That is the point of your, what is that, SGLT2. Okay, let's talk about the next concept, that is your hypoxia. Now hypoxia is a very, very important concept, and many times they have asked the question. So types of hypoxia. Okay, the first type of hypoxia is called as hypoxic hypoxia. So what happens here is that there is a if you go to high altitude, let's speak, if you go to high altitude, okay, so as you go to high altitude, now the problem is that in the atmosphere, partial pressure of the oxygen is reduced. So as partial pressure of the oxygen is reduced, my dear students, what will happen now? What will happen here is that decrease of partial pressure, so automatically person will have an increase of respiratory rate, because your body wants to take more oxygen. You're doing this because for what? For the sufficient oxygen requirement to meet your, cause they having, what is that, hyperventilation. While you are hyperventilating, you will have a loss of CO2. So loss of CO2 will lead to, what is that, respiratory alkalosis. So this respiratory alkalosis itself will further progress into mountain sickness. The drug of choice for the mountain sickness is your acetazolamide. So here there is a decrease of partial pressure, decrease of O2 and decrease of partial pressure in the atmosphere, but the hemoglobin is normal, RBC is normal, respiratory system is normal, everything is normal. Only in the surrounding there is no oxygen, leading to hypoxic hypoxia. Okay, let's go to the next one, anemic hypoxia. When we are speaking of anemic hypoxia, means atmosphere is normal means PO2 in the partial pressure of oxygen in the air is normal, but the problem here is that anemia is there. So there is a less hemoglobin, no hemoglobin or less hemoglobin. So if hemoglobin is not there, so there is nobody else is there to transport the oxygen, right? So that will lead to hypoxia. So basically the hypoxia can be caused, hypoxia means lack of oxygen, that can be caused due to lack of oxygen in the atmosphere, in the surrounding, called as hypoxic hypoxia. So oxygen is there, lungs are working fine, but there is nobody is there to transport the oxygen. So that we will call it as anemic hypoxia. Anemic hypoxia can be seen with two causes. One is anemia itself, and one more is carbon monoxide poisoning. So carbon monoxide, why? Because carbon monoxide has more affinity for the hemoglobin, because of which free hemoglobin will not be there for the transport of oxygen. So that is the story of your anemic hypoxia. Okay, then the next one is the stagnant hypoxia. When we are speaking of stagnant hypoxia, dear students, so stagnant hypoxia is a condition. Stagnant, the word itself is very clear, stagnant or ischemic. So there is a lack of blood supply. There is a lack of blood supply. So oxygen is there, respiratory system is fine, hemoglobin is fine, everything is fine, but blood supply is not occurring due to some vascular disease. If the organ is suffering from hypoxia, we will call it as a stagnant or ischemic hypoxia. Ischemia means lack of blood supply, lack of blood supply. Then we have one more thing called as histotoxic hypoxia, are also called as tissue hypoxia. So what happens, there are some poisons which will go and block the electron transport chain. So specifically electron transport chain. So once electron transport chain is blocked, basically tissue level respiration will not occur. Tissue level respiration will not occur. So that is only called as tissue hypoxia. So that occurs due to blockade of electron transport chain due to, for example, cyanide poisoning. Cyanide inhibits the complex 4 of your electron transport chain. Okay. Hope this part is clear. Let's continue to the next one, that is electron transport chain itself. So to understand the electron transport chain, my dear students, in a cell we will have mitochondria. In a cell, what do we have? Mitochondria. So mitochondria has two layers, outer layer and a inner layer. Outer layer and a inner layer. Okay, outer layer and a inner layer. Okay, so inside of the inner layer we have matrix. We have matrix of the. Then outside of the mitochondria, we will have a cytoplasm, because mitochondria is located in a cell. So consider this is one cell. So in the cell, cytoplasm is there, and also mitochondria is there, mitochondrial matrix. So this electron transport chain is located where exactly? It is located in the inner side, inner membrane. So let's take two membranes. So one is outer membrane and one is inner membrane. So what happens here? So in the electron transport chain, to understand the electron transport chain, I want you people to understand some basic concept of carbohydrate metabolism itself. So for example, from the food you take glucose. From the food you take glucose. Now glucose will get converted into pyruvate. Glucose will get converted into pyruvate. So during this conversion, my dear students, what will happen? It will release some hydrogen ion. It will release some which ion? Hydrogen. This hydrogen will be taken by hydrogen acceptors. Which are those? Hydrogen acceptor. Hydrogen acceptor. Okay. Hydrogen acceptors will take up what is that? Hydrogen. So this pyruvate further enters in, further get converted into acetyl-CoA. Acetyl-CoA will further enter into Krebs cycle. Okay, so during the Krebs cycle also it will give out some hydrogen. All the hydrogen will be taken up by your hydrogen acceptor. So which are the hydrogen acceptor? We have NAD and we have FAD. Okay, after I add the hydrogen, it will become into NADH, NADH, and after adding the hydrogen to the FAD, I will get FADH. Okay, I have two substances, NADH and FADH. NADH and FADH. These NADH and FADH enter into one chain called as electron transport chain. NADH and FADH taken the hydrogen and entered into some chain called as electron transport chain. Where is that electron transport chain is located? On the inner membrane of the mitochondria. So in the inner membrane, in the electron transport chain, we have two important things which are located. So one of them is called as your enzymes. There are some enzymes which are located. These enzymes are only called as complexes. These enzymes are only called as complexes. These enzymes are only called as complexes. Then there is something called as transporters. Then there is something called as transporters. So we have transporters and complexes. So what happens to the complexes and transporters? Let's see. So basically we have complex number 1. Complex number 1, my dear students, they're called as, what is that? The complex number 1 is called as NADH dehydrogenase. Dehydrogenase. So basically this is an enzyme. The name of the enzyme is, what is that? NADH dehydrogenase. Okay. So this NADH dehydrogenase, what it will do, my dear students? It will take the NADH. It will take the NADH and convert it into NAD and hydrogen. It will separate the NADH and it will separate the hydrogen. That hydrogen will be pumped into your intermembrane space. So first complex, what it did? It utilized the, yes, it utilized the NADH and sent the hydrogen into the intermembrane space. While it is breaking the NADH, it will gain 2 electrons. It will gain 2 electrons. It will collect the electrons and give it to a transporter called as coenzyme Q. Coenzyme Q. So other name for coenzyme Q, we also call coenzyme Q. Coenzyme Q is also called as ubiquinone, called as ubiquinone. Ubiquitin अलग है, ubiquinone अलग है बच्चों. Ubiquitin अलग है, ubiquinone अलग है. So we have coenzyme Q. It takes the electrons. It takes the electrons. That is only called as ubiquinone. Ubiquinone. Okay. So it has taken the electrons from whom? It has taken the electrons from, yes, of course, from your, that is your complex number 1. Now complex 2 is there. Complex 2 is called as FADH dehydrogenase. This is also enzyme. So it utilizes the FADH and forms the hydrogen. That hydrogen will be again pumped into, what is that? Pumped into the intermembrane space, while it also generates 2 electrons. All the 2 electrons will be given to coenzyme Q. So far, our complex 1 and complex 2 extracted the hydrogen, sent the hydrogen into the intermembrane space and given the electrons to a transporter called as coenzyme Q. So the transporter is between whom and whom? Complex 1 to complex 1 to, from the complex 1 to, it is transporting the electrons into the complex 3. Okay, which is that complex 3. Okay, so from the complex 3, we call it as cytochrome reductase. Complex 3 is called as cytochrome reductase. This complex 3 will take the electrons and give it to one more person, one more transporter called as cytochrome C. Okay, this cytochrome C will give the electrons to the complex 4. Basically from 1 and 2 electrons are collected and hydrogen is pumped into the intermembrane space. From there electrons go to complex 3. From there electrons go to cytochrome C. Now cytochrome C gives up that electrons to somebody. Who is that? To the complex 4. So what is the name of the complex 4? Is called as cytochrome oxidase. Okay, so this cytochrome oxidase utilizes these electrons and oxygen which came from the respiration. So it will combine the hydrogen and oxygen. It will synthesize the water. We call it as oxidation reaction. What will occur? Oxidation reaction will occur. Now all the hydrogen is collected from all the complexes. It is located where? It is easily located in the intermembrane space. Now these hydrogen, whatever is there, these hydrogen will be utilized by a complex 5. Complex 5 is also called as, name of the enzyme called as ATP synthase. This utilizes that hydrogen and converts ADP into ATP. We call this reaction as a phosphorylation. Okay, phosphorylation. So this phosphorylation is always combined with what? Oxidation. So oxidation and phosphorylation are a combined reaction. Oxidation and phosphorylation are a coupled reaction. They occur together. Okay, very good, very good. So this coupled reaction, so because of this coupled reaction only we are getting ATP. If this coupled reaction is not there, then we'll have a problem. There is a lack of ATP. So if anything is together, automatically what will be the MCQ, sir? MCQ, what we are going to get is, who will separate these two things? So who will separate? Okay, so uncouplers are the substances which separate the oxidation and phosphorylation. So oxidation and phosphorylation is separated because of chemicals such as 2,4 dinitrophenol. 2,4 dinitrophenol. Then we have a drug called as aspirin, and there are some hormones which are found in the body, that is your thyroid hormone, which can also uncouple, and thermogenin. Thermogenin is a substance which is found in the brown fat of the infant, which produces the heat. Okay, so whenever there is an uncoupling, sir, if uncoupling occurs, let it occur, but still reactions are occurring, ATP synthesis should occur, right? No, if they are not occurring together, uncoupled, after uncoupling, what will be the problem, dear students? There is no ATP. There is no ATP, only heat is generated. Only what is generated? Heat is generated. No ATP, only heat generation will occur. So these uncouplers will cause the excessive heat production. Okay, so there is no ATP. So overall, to sum up electron transport chain, everyone will have a confusion in electron transport chain. Remember, we need two things: electrons and hydrogen. Okay, electrons are required for complex 4, that is called as cytochrome oxidase. Cytochrome oxidase. So from the complex 1 and 2, these electrons are collected by coenzyme Q, gives the electrons to complex 3. From there electrons will go to cytochrome C, and the complex 4 utilizes those electrons and forms a water, and it is also utilizing, what is that? Oxygen. Okay, then this complex 1 will send the hydrogen, complex 3 will also send the hydrogen, which is formed in the mitochondrial matrix. So complex 5 will utilize all that that is your what is that hydrogen and synthesize the ATP with the help of a coupled reaction called as oxidative phosphorylation. Oxidative phosphorylation. So this is a story of your electron transport chain and uncouplers, which has been very commonly asked. If there is an uncoupling of what is that oxidative phosphorylation, then definitely the patient will develop what is that excessive heat production, but there is no ATP generation. And uncouplers have been frequently asked previously also, so you need to be very careful with it. So what are the uncouplers? 2,4 dinitrophenol, aspirin as a drug, hormones such as thyroid hormone, then thermogenin, which is a brown fat which produce the heat in the infants. Okay, all right. Once we understood about this, let's talk about what is that inhibitors of electron transport chain. So who will inhibit the electron transport chain? So remember, electron transport chain has complexes, nothing but enzymes. So if enzymes are there, any enzyme is there, there is a possibility of enzyme inhibition. So complex 1 inhibitor, that is your barbiturates and rotenone. These are the two chemicals which are what is that complex 1 inhibitor. Complex 1 inhibitor, barbiturates and rotenone. We have a chemical called as malonate, which is found to be inhibiting complex number 2. And most important one is carbon monoxide and cyanide poisoning. Carbon monoxide and cyanide inhibits complex 4. What is the name of the complex 4? Cytochrome oxidase. Name of the complex 4 is what is that? Cytochrome oxidase. Oligomycin inhibits the complex 5. So here, is there any other fact-based question? So they will ask you. So look at the image and tell me which complex does not interact with intermembrane space. Does not interact with the intermembrane space. Intermembrane space. So this is a very commonly asked, possibly asked question related to the complexes. Complexes itself, if they are asking, this is possible. And poisons, if they are asking, this is the table which one everyone has to remember. So which one? Which does not interact with? Yes, that is your complex number 2. Which complex? Complex number 2. Okay. So the answer goes is complex number 2. Now the next question they can ask you is which complex incorporate the oxygen. Incorporation and use of oxygen by which complex? Use of oxygen by which complex? This is also question which has been asked. That is your complex 4. Complex 4. So complex 4 is also called as cytochrome oxidase. Cytochrome oxidase. Let me quickly tell you all the possible questions which are asked. They will ask you very important aspect. What is that? They will ask you, where does the electron transport chain occur? In the inner membrane of the mitochondria. Then how many complexes we have? 5. How many transporters we have? 2 transporter. One is coenzyme Q, one more is cytochrome C. Then we have one more possible question is this table of poisons, and which have been previously asked also, and especially complex 4 poisons are very important. The carbon monoxide and cyanide. And also they will ask you these 2 possible questions, which does not interact with the intermembrane space, and one more is which one incorporate or utilize the molecular oxygen. That will be your what is that cytochrome oxidase. So these are the important points of electron transport chain. Okay, so all of you know the glycolysis pathway. Just for your satisfaction, let's go through the glycolysis once. After going to the glycolysis once, I'll tell you the steps of the reaction. I have been never asked. Okay, steps of any cycle has been not asked previously. So just let's go through this one quickly. Okay, so we have glucose. Whatever the food comes from the glucose, that glucose undergoes the influence of an enzyme called as hexokinase. Now wherever you hear the term kinase means what, sir? Kinase means very simple. Let's take ATP. ATP has how many phosphate groups? 3 phosphate groups. How many phosphate groups? 3 phosphate groups. So now I have one more substance called as glucose. Now what exactly occurs, my dear student? I will take one phosphate group from the ATP, give it to the glucose, making it into glucose 6-phosphate. Sir, you are giving one phosphate only. Nah, it is located on the 6th carbon. That is why I called it as a glucose 6-phosphate. So anytime a phosphate group is transferred from one substance to another substance, we will call it as kinases. So kinases transfer the phosphate from one molecule to another molecule. So here glucose will take the phosphate from the ATP, get converted into glucose 6-phosphate. Glucose 6-phosphate. This glucose 6-phosphate undergoes the isomerase enzyme effect. Isomer of glucose is what? Fructose. So glucose 6-phosphate will become into fructose 6-phosphate. Okay, so fructose 6-phosphate, my dear students, please listen to me. Fructose 6-phosphate again takes one more phosphate group from the ATP. It will become into fructose 1,6 bisphosphate. 1,6 bisphosphate. So this fructose 1,6 bisphosphate, under the influence of aldolase, it will give rise to what is that? Two substances. Under the influence of aldolase, it will give rise to two substances. One is GLAP. What is GLAP? Glyceraldehyde phosphate, phosphate, and DHAP, dihydroxy acetone phosphate. Okay, now dihydroxy acetone phosphate will again get converted into GLAP. So now listen to me very carefully. Fructose will give rise to one GLAP, one DHAP. Now this DHAP becomes into GLAP. So earlier I had one GLAP. Now from the DHAP I got one more GLAP. So totally I will have two GLAP. So from the GLAP all the reaction happens twice. So that is why I will use the number 2 here. Okay, so if anything occurs, two GLAPs will be formed. So that two GLAPs will go into the reaction further. So this glyceraldehyde phosphate will get converted into 1,3 bisphosphoglycerate. During that time, NADH is produced. So hydrogen is secreted. So because of that hydrogen acceptor will come. Hydrogen acceptor will take up your, what is that? Hydrogen acceptor will take up your hydrogen. It will take up the hydrogen and become into NADH. So this is the story of your, what is that? Story of your, that is your NADH formation. This 1,3 bisphosphoglycerate will get converted into 3-phosphoglycerate under the influence of an enzyme called as phosphoglycerate kinase. It will synthesize ADP to ATP. Basically, I am using kinase. So I am taking one phosphate from the phosphoglycerate and giving it to the ADP, so that ADP will become what? ATP. ADP will become what? ATP. Okay. So two ATPs are formed. So then 3-phosphoglycerate becomes into 2-phosphoglycerate. Means here we are changing the position of phosphate from one carbon to another carbon within the same molecule. So here it was in the third position, it became into second position. So within the same molecule, if you are changing the carbon location, then you are going to use an enzyme name called as mutase. So 3-phosphoglycerate will get converted into 2-phosphoglycerate. So these 2-phosphoglycerate will get converted into phosphoenol pyruvate, and under the influence of an enzyme called as pyruvate kinase, your ADP will get converted into ATP. So here we are going to get 2 ATP. Here we are getting 2 ATP. So totally ATP generated is 4 ATP is generated. Okay, and NADH is how many? 2 NADH. So 2 NADH, that means it is equal to 5 ATP, sir. Why 5 ATP? 1 NADH is equal to 2.5 ATP. 1 NADH is equal to how many ATP in glycolysis? 2.5 ATP. So 2 NADH will give me how many? From the NADH, I'll get how many ATPs? 5 ATP. 5 ATP. Sir, how do we get from NADH? How do we get the ATP? We get the ATP because this NADH enters into electron transport chain. Electron transport chain will give you, what is that? Will give you the ATP. So totally how much we gain, sir? Gain of ATP, 1 glucose will give rise to 9 ATP. Okay, but loss is also there. So loss is how many? Here we are using 1 ATP. Here we are using 1 ATP. Loss 2 ATP will be there. So overall net ATP in a glycolysis, that too in a aerobic glycolysis. In a aerobic glycolysis is 7 ATP. So one glucose gives how many ATPs? 7 ATPs in the pathway of glycolysis. So what is glycolysis? Glucose to pyruvate. Okay. So the rate limiting enzyme, they will ask you. What is the rate limiting enzyme? This is the point to be remembered. Phosphofructokinase. What is that? Phosphofructokinase. This enzyme concentration dictate the whole of your, what is that? Complete glycolysis. Okay. Now, this is a very important point to be remembered, that is your rate limiting enzyme. Glycolysis occurs in almost all the tissues, but they will ask you in the cell where it will occur, whether in the cytoplasm, whether in the mitochondria. You need to be very careful. It occurs in the cytoplasm. It occurs in the cytoplasm. Okay. Now we had an enzyme. Remember hexose kinase. So hexose kinase has a isoenzyme. Isoenzyme means different location doing the same function. Enzyme is located in the different location but doing the same function. I call it as a isoenzyme. So this insulin has a hexokinase has two isoenzymes, that is hexokinase and glucokinase. Okay, hexokinase is located in almost all the tissues, but glucokinase is located only in the liver. So insulin will do what? Insulin has no effect on the hexokinase, but whenever insulin comes, it will go and stimulate the glucokinase. So glucokinase is stimulated by which substance? Insulin. This is a very, very important question. So what is that? Insulin stimulated by what? Insulin is stimulating the glucokinase. Insulin is stimulating the glucokinase. Okay. So let's talk about a disease called as pyruvate kinase deficiency. So pyruvate kinase deficiency. So usually what will occur? So in the RBC, So in the RBC, my dear students, no mitochondria. No mitochondria. Okay. In the RBC, there is no mitochondria. If there is no mitochondria, what that means how it will play a significant role here. Let's understand. Now look here. Let's take the glycolysis cycle. So glycolysis is occurring, sir. Where? In the RBC. In the RBC, if this enzyme, which enzyme? Pyruvate kinase. Which enzyme? Pyruvate kinase. Which enzyme, sir? Pyruvate kinase. If the pyruvate kinase is not there, automatically 2 ATP is not synthesized. 2 ATP is not synthesized. Okay. Now, NADH is also of no use in the, no use in the RBC. Why NADH is of no use in the RBC? Because the RBC has no mitochondria. Only in the mitochondria electron transport chain occurs. So only in which cell? Only in the mitochondrial cells the use of NADH will be there. Here it is of no use. NADH is of no use. So basically I am getting 2 ATP only, because this step also will not occur due to lack of pyruvate kinase. Okay, and only this step will occur, giving me how many ATP? Only 2 ATP will be there, and this 2 ATP is produced and 2 ATP we are utilizing. So automatically what will happen in the RBC? If there no mitochondria is there, so if there is a deficiency of pyruvate kinase, automatically that will lead to what is that? ATP depletion. ATP depletion will occur. So due to ATP depletion, that will lead to what is that? Hemolysis. So pyruvate kinase deficiency is a hemolytic anemia which is due to lack of pyruvate kinase enzyme. It is an autosomal recessive disorder. So please be very careful with it. Okay. Then rate limiting enzyme for the, so I'm not going to discuss the Krebs cycle here. So rate limiting enzyme for the Krebs cycle is your isocitrate dehydrogenase. Isocitrate dehydrogenase is the rate limiting enzyme for your Krebs cycle. So Krebs cycle starts with what? Starts because of your acetyl-CoA. Acetyl-CoA is the substrate for your, what is that? Krebs cycle, and the rate limiting enzyme is your isocitrate dehydrogenase. Okay. Then let's talk about the fructose. Let's talk about your fructose, sir. Quickly, let's talk about your fructose. Now, whenever you eat fructose under the influence of an enzyme called as fructokinase, it will form something called as fructose 6-phosphate. So should we remember these steps or should we remember something else? So based out of these steps, I'll be teaching you the diseases. Remember the diseases. Okay, fructose 6-phosphate will further get converted into what is that? But the influence of phosphofructokinase, it will give rise to fructose 1,6 bisphosphate. Okay, so wherever kinase comes, we are adding the phosphate or removing the phosphate into some molecule. So this fructose 1,6 phosphate under the influence of an enzyme called as aldolase B. Aldolase B is a very important subtype. We need to remember aldolase B. It will give rise to GLAP and DHAP and DHAP. It will give rise to GLAP and DHAP. Now, from the GLAP, DHAP, it is similar to that of glycolysis only. So, now what happens if there is a deficiency of fructokinase? If there is a deficiency of fructokinase, it will lead to a condition called as essential fructosuria. Means person eats the fructose containing food, fructokinase is not there, so fructose will it get metabolized or no metabolism of fructose? There is no metabolism of fructose because fructokinase itself is not there. So immediately that will lead to that fructose will remain in the blood. So undigested, unmetabolized fructose from the blood enters into the urine, leading to essential fructosuria. Okay, essential fructosuria. Okay, then there is one more possibility. If there is a deficiency of aldolase B, if there is a deficiency of aldolase B, dear students, it will give rise to something called as what is that? HFI, hereditary fructose intolerance. Hereditary fructose intolerance. It is caused by the mutation of a gene called as ALDO B gene mutation, and it is a autosomal recessive. So fructose related to disorder, fructose essential fructosuria, that is due to deficiency of lack of which enzyme? Fructokinase. Lack of which enzyme? Fructokinase. And if there is a lack of aldolase B, it will lead to a disease called as hereditary fructose intolerance. Hereditary fructose intolerance. Okay. Then let's go to the next one, that is your galactose metabolism. So let me quickly revise the galactose metabolism and teach you the diseases. Okay. So here what is there, my dear students, we have some substance called as UDP glucose. We have a substance called as UDP glucose, and we have one more substance from the food you ate, that is your galactose. You ate which substance? Which one? Galactose. So this galactose, dear students, will get converted under the influence of an enzyme called as galactokinase. Galactokinase, it will get converted into galactose 1-phosphate. 1-phosphate. Now, what happens is that so because of there is an enzyme, what exactly it is doing? That enzyme is called as galactose 1-phosphate uridyl transferase. Transferase. So basically it will create something. What exactly is that? So it will take the galactose and UDP glucose and form something called as UDP galactose. So galactose will get added with the UDP and glucose will get added to the phosphate, leading to glucose 1-phosphate. So this glucose 1-phosphate can further get converted into glucose 6-phosphate and enter the glucose metabolism. Now this UDP galactose, whatever is there, can convert back into UDP glucose with the help of an enzyme called as epimerase. What is that? Epimerase. Okay. So if there is a deficiency of this particular enzyme, galactose 1-phosphate uridyl transferase, automatically galactose will form galactose 1-phosphate, but further it will not get converted into UDP galactose. Because of that, you have a problem, that is galactosemia. So galactosemia is a lack of this enzyme, galactose 1-phosphate uridyl transferase, and it will lead to the autosomal recessive disorder associated with one important symptom, that is your oil drop cataract. So there can be image based question. They'll give you an image of oil drop cataract and they will ask you this is due to deficiency of which enzyme? Galactose 1-phosphate uridyl transferase. Deficiency leads to what is that? Galactosemia. Other difficulties such as the motor difficulty, fine and gross motor difficulty, speech difficulty, intellectual disability will be there. But very important eye related clinical feature they'll ask you, that is only your what is that? That is your galactosemia. Okay. So once we understood about galactosemia disorder, let's go to the next one, glycogen storage disease. What is that? Glycogen storage diseases. So glycogen storage diseases has been a very important and the favorite examiner's favorite question. So let's discuss about that. So let me take up an image, one simplified image I will take. Okay. So this image will be discussing about glycogen metabolism. Followed by the glycogen metabolism, we will understand about what is that, sir? Yes, understand about the diseases. Normally, you eat the food. In the food, there is a glucose. In the food, there is what is that? Glucose is there. So if your body has a excessive glucose, your body will throw the glucose out or it will store. Yes, it want to store. It will store it in the form of something called as glycogen. Called as glycogen. Now, glucose will get converted into glucose 6 phosphate under the influence of hexokinase. Same. Now, glucose 1 phosphate will 6 phosphate will get converted into glucose 1 phosphate. This glucose 1 phosphate will get converted into UDP glucose. Now, UDP glucose, my dear student, undergoes the influence of two enzymes. One is glycogen synthase and one more is branching enzyme. So, glycogen synthase, what it does? So, it will add the glucose. It will add the glucose, one glucose to another glucose to another glucose to another glucose. It will create a linear chain. Glycogen synthase is creating a linear chain. In the linear chain, my dear students, you have a bond called as alpha glycosidic bond, that is called as 1,4 bond. Means first carbon of this glucose and fourth carbon of this glucose are entering the bond formation. So 1,4, what is that? Alpha bond will be present, alpha glycosidic bond. Now, so this is creating which one? Glycogen synthase. But whenever you want to make a branch, whenever you want to make a branch, here we will not have a 1,4 bond, rather we will have a 1,6 bond. 1,6 bond means first carbon of this glucose and sixth carbon of this glucose are going into the bond formation. So that is only called as branch formation, called as branching enzyme, and it has stored the glycogen. It has stored the glycogen. So this is only called as glycogenesis. This process is only called as glycogenesis, or also called as glycogen synthesis. Okay. Now, whatever the glycogen which is formed, whenever we want to break it, what we will require? We will require an enzyme called as glycogen phosphorylase. So now there was a branch formation, there was a linear chain. There are two things are there: branch formation and linear chain. So we are trying to break the linear chain. So to break the linear chain, let's imagine. So I will break up this particular one. I will break this particular bond. For example, I will have the one glucose molecule separated. I will have glucose 1 phosphate. Okay, and whatever the left out part is there, that is called as limited extreme. We will call it as a limited extreme. Remember what is that? Limited extreme. So linear chain is broken by which one? Glycogen phosphate. Wherever there is a bond formation, that is your 1,6 bond formation is there, that bond will be broken by which enzyme? Debranching enzyme. Which enzyme? Debranching enzyme. And it will give glucose 1 phosphate. That glucose 1 phosphate will get converted into glucose 6 phosphate under the influence of an enzyme called as glucose 6 phosphatase, that will get converted back into the glucose. So this is the story of your glycogen synthesis. Okay, now glycogen synthesis and breakdown we understood. So why it is important for us? Because there are some rare disorders in which these enzymes are defective. So there is, for example, glycogen synthase is defective. Okay, glycogen phosphorylase is having a defect. Okay, debranching enzyme has a defect, branching enzyme has a defect. So during that time, glycogen will start to get deposited in the body, leading to called as glycogen storage diseases. So we have 6 main important types. We have 7th one also, but main important are 6 important diseases. The type 1 glycogen disease, type 1 glycogen storage occurs due, that is, the name is called as a Van Giereg's disease. What is that? Van Giereg's disease. It is due to deficiency of which enzyme? Glucose 6 phosphatase deficiency. Where did we learn about glucose 6 phosphatase? Here. So lack of glucose 6 phosphatase will lead to which enzyme? Van Giereg's disease, in which hepatomegaly can be there. But very many students make one small mistake, remembering only hepatomegaly. Van Giereg's disease is a remembering the hepatomegaly is a dangerous game, because hepatomegaly can occur with other diseases also. There is no mandatory rule that hepatomegaly is seen only with the Van Giereg's disease. So you need to remember the enzyme deficient is glucose 6 phosphatase, not 1 glucose phosphatase, glucose 6 phosphatase. Okay, the second one is called as type 2 glycogen storage disease, in which what happens, my dear students, we had a glycogen which was formed. Now, glycogen, whatever is formed, it can enter into lysosome. It can enter into what is that? Lysosome. So, in the lysosome, we have what is that? Glycogen which has entered. Now, this glycogen in the lysosome is metabolized by an enzyme called as acid maltase. What is the name of the enzyme? Acid maltase. So, if there is a deficiency of acid maltase, it will lead to a disease called as Pompey's disease. What is that called as? Pompey's disease. So acid maltase deficiency. These patients will have mainly affected systems are muscle and heart, my dear student. Muscle and heart. So the patient will have hypotonia, muscle weakness. Then later, if you go and investigate, patient can have cardiomegaly due to excessive of glycogen deposit. Where exactly? In the lysosomes. Lysosomes due to deficiency of which enzyme? Acid maltase. Okay. Type 3 is called as Cory's disease. Cory's disease is due to deficiency of debranching enzyme. Type 4 is called as Anderson. That is due to deficiency of branching enzyme. Okay. Then type 5 is called as McArdle's disease. McArdle's disease is due to deficiency of which enzyme? Here we have glycogen phosphorylase. So McArdle's disease is due to glycogen phosphorylase deficiency. Her's disease also is due to glycogen phosphorylase deficiency. So Her's and McArdle, same thing, but only problem here you need to remember in which location. So McArdle's disease is due to glycogen phosphorylase deficiency in the muscles, and Her's disease is due to hepatic, means glycogen phosphorylase deficiency in the liver. So how to remember these diseases? So let me give you some simplified tricks so that you can remember better. Okay, remember Anderson branching enzyme deficiency. Okay, then Cory's is due to debranching enzyme deficiency. Okay, debranching enzyme. Okay, so remember with the mnemonic A, B, C, D. A for Anderson, B for branching defect, C for Cory's, D for debranching defect. That is one thing. M for McArdle's disease, M for glycogen phosphorylase deficiency in the muscle, H for Her's disease, H for hepatic glycogen phosphorylase deficiency. So now type 2 is acid maltase deficiency and type 1 is von Wierecht's disease. So this is a story of your glycogen storage disorders. A for Anderson, B for branching defect, C for Cory's, D for debranching defect, M for McArdle's, M for muscular glycogen phosphorylase deficiency, H for Her's disease, H for hepatic glycogen phosphorylase deficiency. Then acid maltase is due deficiency leads to pompous, and glucose 6 phosphatase leads to type 1 called as von Wierecht's disease. So this is the story of your glycogen storage disease. What is that? Glycogen storage disease. Clear everybody? I hope this part is clear. Let's go to the next disease here only in the carbohydrates chapter only, that is your G6PD deficiency. Again, this is very frequently asked. So what is the G6PD deficiency? Let's quickly recall about the G6PD, where it comes and how it plays a role. After that, we'll be able to understand what is that. We will be able to understand the what is that. That is your disease itself. Okay, let's understand HMP pathway. Now HMP pathway, what is the important things which are important for our exam is what is the use of HMP pathway. The HMP pathway has one important enzyme. It has an enzyme, very important enzyme called as glucose 6 phosphate dehydrogenase. Glucose 6 phosphate dehydrogenase. So HMP pathway produce two important things. It will produce two important things. It will produce, one is called as NADPH. What is that? NADPH. And also this NADPH, and also it produces ribose sugar. It produces ribose sugar and NADPH. Two substances are produced. Okay. Now let's understand the use of NADPH. Where is NADPH useful? Okay. So to understand that, let's dive into red blood cell. So in the red blood cell, my dear students, we have something called as glutathione. What is that? Glutathione. So the glutathione, whatever we have, it is in the form called as a reduced glutathione. This reduced glutathione undergoes a reaction called as peroxidation. Which reaction? Peroxidation, and becomes into glutathione in which form? Glutathione into oxidized form. Okay, so oxidized form. Now the question comes, sir, if peroxidation is occurring, what is the purpose of peroxidation? So while peroxidation is occurring, it is taking the hydrogen peroxide and it will get converted into water, because hydrogen peroxide creates what? Free radicals. So basically, when glutathione undergoes peroxidation, it will remove H2O2. It will remove what? H2O2. This is a very, very important point to be remembered. Okay, it will remove the H2O2. So this oxidized glutathione will undergo a reaction called as reduction reaction. For the reduction of glutathione, I will require NADPH. I will require, what is that? NADPH. NADPH comes because of which pathway? HMP pathway, with the help of which enzyme? G6PD. Which enzyme? Glucose 6 phosphate dehydrogenase. Glucose 6 phosphate dehydrogenase. Okay. So this is how our body is removing free radicals in the red blood cell. How it is removing? By the help of peroxidation. For the peroxidation reaction to occur, who is required? Glutathione is required. That is in the reduced form. It will undergo oxidation. Again, reduced form will come because of NADPH. So once we understood about this, let's talk about what is that? Let's talk about G6PD deficiency. So if there is a lack of G6PD, automatically there is a lack of NADPH. If there is a lack of NADH, reduction will not occur. If reduction will not occur, it will not have a peroxidation. So automatically what will happen? If there is no G6PD in the red blood cell, H2O2 is not metabolized, leading to excessive accumulation of what is that? H2O2, excessive accumulation of H2O2. So exactly what happens is that in the G6PD deficiency, there is an increase of H2O2 in the RBCs. Now, this is a type of free radical. This is a type of free radical. So, this free radical, whatever is there, so that will interact with the cell membrane to create a Heinz body. Means, what is Heinz body? Heinz body is nothing but, so this peroxide interact with the cell membrane of the RBC. Interact with what of the RBC? Cell membrane of the RBC. So, these Heinz bodies are called as lipid peroxide bodies. Lipid peroxide bodies. So lipid peroxide bodies, the Heinz bodies, after your spleen remove the Heinz body will create something called as which cell? Bite cell. Body will create something called as bite cell. So this is the peripheral smear finding. So there are clinical features are hemolytic anemia. Hemolytic anemia is what? A sudden onset of jaundice, and also child will have an anemia. Okay. Now, normally if the child has a G6PD deficiency, nothing problem will occur. Basically, life will be normal only. But whenever there is more H2O2, only during that time hemolysis will occur. Means child with a G6PD deficiency can have a healthy life. Only during the conditions where there is an increase of free radicals, that time hemolysis will occur. So what are the substances which causes the free radical increase? So free radical increase occurs because of the old anti-malarial drugs. And also inflammatory condition, means child has a urinary tract infection, respiratory tract infection. During that time, free radicals will be more. Then sulfur containing drugs also can lead to the same problem. Okay. Then you have your aspirin and fava beans. They can precipitate the G6PD deficiency. Okay. So the gold standard is G6PD assay. Many students make a mistake of marking Heinz body or bite cell. Not the Heinz body, not the bite cell, which is useful. The gold standard investigation is measuring the level of G6PD. That is only G6PD assay. That is only your, what is that? G6PD assay. That is a gold standard investigation for your, what is that? Very good. That is for your G6PD deficiency. Okay. So these are the important points which are asked from the carbohydrate. So I have tried to simplify as much as possible, but these are very, very important, very commonly asked questions from the carbohydrate. It has covered all of it. Now, for example, if you haven't studied the whole biochemistry of your, what is that? That is your carbohydrate. At that time also you need to know at least these particular points which I have told so far. Okay, I have told so far, these are very, very important. Let's go to the amino acids chapter. So these are the two important chapters with many questions and other things also there which we will talk about. So amino acid with no chiral carbon. First we need to understand what is that chiral carbon. Amino acid with a chiral. So basically chiral carbon is nothing but a carbon which is binding. For example, it is bound to hydrogen, it is bound to carbon, it is bound to OH, it is bound to, let's imagine for example, NH3. Okay, so it is bound to 4 different substances. Okay, all right. Now 4 different substances, if a carbon is binding, we will call it as a chiral carbon. We will call it as a chiral carbon. Chiller carbon nahi hota beta. What is that? Chiral carbon. What is that? Chiral carbon. Chiral carbon means which is bound to 4 different groups. We will call it as a chiral group. What is that? Chiral group. So chiral carbon, the amino acid which does not have any chiral carbon is glycine. which does not have any chiral carbon is glycine. Okay. Now let's talk about the structure of the amino acid. कभी कभार क्या कर देता पता है, ऐसा दे देगा R with a carbon with a COOH, okay, and a NH3, okay. तो ये क्या होता है, he will take a photo of this and he will ask you what identify the given structure. So you should not panic. पहले देखो, ध्यान से देखो तो सही, देखो तो यहाँ पे तो देखो, you have ammonia group. So ammonia group, and we have an acid group. We will call it as amino acid. So two functional groups should be there, ammonia group and acid. So for example, one amino acid bind. So if you take a protein, all the proteins are made out of amino acid. So if one amino acid binding with another amino acid, where it will bind? This is the question. So R group is there. Let's imagine COOH is there. Okay. Now here I will write NH3. So still this is a amino acid. Yes, it is a amino. One amino acid's ammonia group binds with the COOH group of another amino acid. We call it as a peptide bond. Peptide bond. This is called as peptide. So peptide bond is located between the ammonia group of one amino acid and amino group of one amino acid and COOH group of another amino acid. I will call it as, what is that? That is only called as peptide bond. Okay. Now we have amino acid. The classic example for amino acid, basically amino acid, if its amino group, if it is not free, then we will call it as a amino acid. What is amino acid? If ammonia group of amino acid is not free, we will call it as a amino acid. Classic example for the amino acid you have is proline. Okay, one amino acid binds with another one is peptide bond. Where is that bond located also? We studied. Okay. So, classification of amino acid. Based on the nutritional requirement, we have essential amino acid and non-essential amino acid. Based on the structure also, we have the classification. Simple amino acids are your glycine and alanine. Glycine and alanine have a simple structures. Okay. Then branched chain amino acid, we have leucine, isoleucine and valine. Leucine, isoleucine and valine. Okay. Then sulfur containing amino acids are methionine and your cysteine. Sulfur containing amino acids are your methionine and cysteine. Then hydroxyl containing amino acids are serine and threonine. Okay. So we have something called as the 21st amino acid. 21st amino acid. Usually we have 20 amino acid. Later we discovered one more amino acid, we will call it as 21st amino acid. After that, we discussed one more amino acid called as pyrrolysine. Selenocysteine is coded by UGA and pyrrolysine is coded by UAG. Okay. So, this is one way to classify. Another point of the classification which I want you people to remember, essential and non-essential amino acids. So, essential are mandatorily essential, means it should be taken from the diet. Non-essential means your body will produce them. Okay. So, essential amino acid, we have one amino acid called as tryptophan. What is that? Tryptophan. We have our valine. Okay. Then we have our threonine. Threonine is a sulfur containing amino acid. Then we have your isoleucine. Okay. Then we have your, what is that? That is your leucine. Okay, isoleucine, leucine, and we have one more amino acid called as lysine. Okay, one more amino acid called as lysine. Okay, then we have one more called as valine and phenylalanine and your phenylalanine. Okay, so these are the amino acids which are essential. You can remember it. So what is that? You can remember it with the help of a mnemonic TV till 8 p.m. TV till 8 p.m. Okay. So this is a classic mnemonic which you can remember. Okay. So TV till 8 p.m. So they are mandatorily essential amino acid. Okay. So T for tryptophan, V for valine, T for threonine, I for isoleucine, L for leucine, lysine, valine and phenylalanine. These are mandatorily conditionally essential amino acids. Okay. All right, let's continue to the next particular aspect. What is that? That is your urea cycle. So to understand the urea cycle, before I jump into the urea cycle, I would like to teach you people how our body handles any proteins. Okay. So from the food, food consists of what is that? Proteins. From the food, we will get proteins. So proteins come into the body, so whatever protein rich diet you take, right, so body will not utilize the protein directly, rather this protein, once you take it, this protein will break into amino acid, what is that, amino acid, break into amino acid, and form a new proteins, which is required for our body. So according to the body's requirement, according to the body's genetic makeup, they form a new protein. So after forming a new protein, they do their function. After function, these proteins will break down into amino acids. Now these amino acids will have ammonia, has what is that? Ammonia. Now this ammonia is a toxic metabolite. This toxic metabolite will get converted into urea. Now this urea is removed by the body. This urea is removed by the kidneys. So that is how your body is handling the protein. So proteins, whatever whey protein, whatever the protein you take, do they directly work as a protein? No, usually they work as what? They will give the source of amino acids, and this they will do their new protein synthesis, do the function, and break down into ammonia. Ammonia is a toxic waste which has to be removed from the body with the help of urea cycle. Ammonia gets converted into urea. Now urea will be removed. Okay. So basically, what we have is, so we have, let's take in the brain, sir, in the brain and in the muscle, So in the brain and the muscle, what will happen? We have a waste substance. What is that? Waste substance, that is your ammonia. Now all the ammonia in the brain will be taken up by an amino acid called as glutamate. So glutamate takes up, what is that? Glutamate plus ammonia. Glutamate plus ammonia will give rise to something called as glutamine. This glutamine goes to liver. Goes to what? Liver. Glutamine goes where? To the liver. Now in the muscle, what will happen? You have glutamate. Which has taken the ammonia. This glutamate combines with pyruvate. Forms a alanine amino acid. Now this alanine amino acid will transport the ammonia to the liver. So basically they will ask you, from the brain, who is transporting the ammonia? Now you people should be clearly knowing the answer. Glutamine. And from muscle, who is transporting? Alanine. So both of them takes the ammonia, they carry it to the liver. In the liver, what will happen? Urea cycle will occur, sir. So in the liver, this ammonia will be unloaded. So ammonia is loaded onto the glutamate and alanine. They brought the ammonia to the liver. So in the liver, they will unload the ammonia. So if they unload the ammonia, now this ammonia combines with carbon dioxide in the liver, especially in which part of the liver? In the mitochondria of the liver. Carbon dioxide combines with ammonia. With the help of an enzyme called as carboxyl phosphate synthase, which is also called as CPS. Which enzyme? CPS. What is that? CPS, carboxyl phosphate synthase. It will create something called as. So the difference is this only. Alanine is a combination of glutamate and pyruvate. So now glutamate will get converted into glutamine. Okay. So that is the thing. That is the difference we have. We should not get confused. Okay. All right. So carboxyl phosphate synthase will create something called as substance called as carbamyl phosphate, which is occurring where? Mitochondria. So this carbamyl phosphate combines with a substance called as ornithine. Remember, that is why we call it as an ornithine cycle. Urea cycle is also called as ornithine cycle. Okay. So carbamyl phosphate combines with ornithine and gives rise to a substance called as citrulline with the help of an enzyme called as OTC, ornithine transcarbamylase. So it will give rise to what is that? Citrulline. So this citrulline, this citrulline further gets converted into arginosuccinate and forms an amino acid called as arginine. So this is a key point to be remembered. So which amino acid is formed? Arginine is formed. This arginine, under the influence of an amino acid, an enzyme called as arginase, it will give rise to urea and ornithine. This urea is eliminated. Okay, eliminated. Okay, so eliminated. So the removal will occur. So there are two important enzymes we need to remember. CPS. CPS is what is that? Carbamyl phosphate synthase. What is that? Carbamyl phosphate synthase. So carbamyl phosphate synthase is which type of enzyme? Rate limiting enzyme for the urea cycle. It is occurring both in the cytoplasm and mitochondria. Which amino acid forms the urea? They will ask you. Urea is formed by your arginine. Is your arginine. Very, very important point to be remembered. And main importantly, so that is your carbamyl phosphate synthesis is the rate limiting. Second enzyme is ornithine transcarbamylase. Okay, so they will ask you what is the rate limiting enzyme? Carbamyl phosphate synthesis, that is carbamyl phosphate synthase. Carbamyl phosphate synthase. Which amino acid is responsible? That is your arginine. And they will ask you, it occurs in both cytoplasm and in the mitochondria. It occurs in both cytoplasm and mitochondria. So if at all there is a defect of the enzyme, if there is a lack of enzyme, they will lead to hyperammonemia. So disorders of urea cycle leads to hyperammonemia. So excessive ammonia due to lack of which enzyme? That is enzymes which is responsible for the urea cycle. Okay. So if at all ornithine transcarbamylase and if there is a CPS defect, CPS, it will lead to hyperammonemia. Type 1 hyperammonemia is due to deficiency of CPS1. So there will be increased level of ammonia in the blood. Increased level of ammonia in the blood. But if there is a deficiency of OTC, ornithine transcarbamylase, so if there is a deficiency of ornithine transcarbamylase, there is an increased amount of carbamyl phosphate and also increased amount of ammonia. Both of them will be elevated. Both of them will be elevated. That is only your increase of ammonia and also increase of carbamyl phosphate. Carbamyl phosphate. So these are a previously asked question. Due to deficiency of OTC, what and all will be elevated? Ammonia will be elevated and also carbamyl phosphate will be elevated. So this is a very, very important question. So if there is a defect of urea cycle, if due to any injury or due to if any disease, if it causes defect of urea cycle, it will lead to a problem. What is the problem it will lead to? It will lead to hyperammonemia. Okay, let's start off with the metabolism of what is that? Metabolism of some amino acid. So that is aromatic amino acid, that is your phenylalanine. Aromatic amino acid called as phenylalanine. Okay, how does phenylalanine work and what is the uses of phenylalanine? Let's see. And this is a very, very important concept. So let's understand this. You have an amino acid called as phenylalanine, sir. Amino acid called as phenylalanine. This phenylalanine undergoes a reaction called as hydroxylation. What is that? Hydroxylation means adding of the OH group. Adding of the OH group. So who is undergoing hydroxylation? Phenylalanine is undergoing hydroxylation. The name of the enzyme is called as phenylalanine hydroxylase. The name of the enzyme is phenylalanine hydroxylase. Phenylalanine hydroxylase. This phenylalanine hydroxylase will give rise to some amino acid called as a tyrosine. Will give rise to some amino acid called as tyrosine. This tyrosine, my dear student, this is a very, very important point to be remembered. So from the tyrosine, what and all formed in the body? So tyrosine is responsible for the synthesis of adrenaline, noradrenaline, and your dopamine. So they are your what is that? Catecholamines. Catecholamine synthesis occurs due to what? Occurs due to tyrosine. Okay. So it is also responsible for melanin production. It is also responsible for what production? Melanin production. And this is also responsible. Don't get confused. Melatonin is produced by tryptophan. Tryptophan produces melatonin. Melanin is produced by tyrosine. Melanin is produced by tyrosine. It might sound very easy right now, but this is a very confusing point on the day of exam. Because of this melanin melatonin confusion, on the day of exam, you start to have panic, like, by looking at this question, you'll start to get scared and you start to think like which one is what. So I don't want you to go through that right now itself. Remember, tyrosine, melanin, tyrosine, melanin, tyrosine, melanin, and melatonin, tryptophan, melatonin, tryptophan, melatonin, tryptophan. Okay, don't get confused. It is also responsible for the production of T3 and T4, T3 and T4. Okay, so if at all there is a deficiency of phenylalanine hydroxylase, if there is a deficiency of phenylalanine hydroxylase, no tyrosine, no adrenaline, noradrenaline, no melanin, no T3 and T4, no T3 and T4. So that is what will happen due to lack of which enzyme? Phenylalanine hydroxylase. Phenylalanine hydroxylase defect. It is due to genetic defect in which there is a deficiency of phenylalanine hydroxylase. So there is no formation of tyrosine, leading to which one? Phenylketonuria, PKU, phenylketonuria. So in the phenylketonuria, mental retardation will be there. Why mental retardation? Because lack of T3, T4. If T3, T4 is not there, it will lead to defect of the brain. It will lead to brain developmental defect called as, that is only called as mental retardation. Skin will become pale. Why skin will become pale? Why skin becomes pale? Because there is a lack of melanin. Then blonde hair. So looking at the pale skin and blonde hair, wow, very beautiful, but also has a main problem, that is mental retardation. Mental retardation. Okay. So this mental retardation, and also the patient will have a mousy odor. These are the clinical feature associated with your, what is that? Aromatic amino acid defect, that is phenylketonuria. Phenylketonuria. All right. So once we understood about the phenylketonuria, let's talk about the next important point, that is your formation of T3 and T4. So formation of T3 and T4, I'm not going to complicate it. So I'll just quickly recap everything. So normally whatever the iodine you eat from the food, that will be taken up by your thyroid gland with the help of a symporter that is only located on your thyroid cell, called as NIS, sodium iodine symporter. This iodine comes into the cell. This iodine will get, so this iodide will get converted into iodine and enters into this side called as colloid. Okay, enters into this side called as colloid. So for this entry of the iodine, we require a special transporter called as pendrin. What is that? Pendrin. That is your, what is that? Pendrin. Okay. Now the next thing what will happen, iodine is coming into colloid and sitting there. Now through the protein synthesis, we get a, in the epithelial cells of the thyroid gland, we get a something called as thyroid globin. That thyroid globin comes into the colloid. So right now colloid has both of them, iodine and thyroid globin. So if you consider this is a thyroid globin consists of an amino acid called as tyrosine. Thyroid globin consists of an amino acid called as tyrosine. So to this tyrosine, I will add iodine. To this tyrosine, I will add iodine. So this adding of tyrosine with the iodine is only called as coupling. For the coupling, we require an enzyme called as TPO, thyroid peroxidase. Which enzyme? Thyroid peroxidase. So after adding of the tyrosine, we'll have a monoiodotyrosine, we'll have diiodotyrosine, T3 and T4. So this T3 and T4, whenever is needed for the body, it will secrete the T3 and T4. Secrete the T3 and T4. So this is the important aspects of your, what is that? Formation of T3 and T4. So TPO is inhibited by some drugs. Which are the drugs which inhibits the TPO? Your propyl thiouracil, your carbimazole, your methimazole, all of them does what is that? Yes, inhibition of the thyroid peroxidase. That is why we use them in the treatment of hyperthyroidism. Which drug is safer for the pregnancy? So first trimester pregnancy, the safer drug is PTU for the hyperthyroidism. Okay, so we have T4 and T3. This T4 and T3 based questions also which are asked frequently. So I want you to understand in the blood. So quantity, let's talk about quantity, amount of T4 and T3. Amount of, what is that? T4 and T3. Quantity of T4 is more than T3. Quantity of T4 is more than T3. This is a point to be remembered. T4 quantity is more than T3. And potency means which is strongly acting. So T3 is more stronger than T4, sir. T3 is more stronger than T4. Okay. So whenever, for example, let's imagine you are staying in India in some warm place, in not some in cold place, very warm place somewhere you are staying. Okay. Suddenly you are sent to, let's imagine, Russia or Ukraine. So in the Russia or Ukraine, it's very cold. So if your body has to make more thyroid hormone and to maintain the body temperature, it will take more time. Now what you have to do, sir? Yes, please understand. Now what your body will do? Your body is brilliant. Body immediately for adoption, for increasing of the heat production, what your body will do, your body does one simple thing. What is that? It will do conversion. So immediately for the rapid use, there is a peripheral conversion. There is a peripheral T4 to T3. T4 to T3. Why T4 to T3? Because T3 is the most active form. So that is why peripherally we can have a conversion of T4 to T3. This peripheral conversion of T4 to T3 is done by deiodinase. So this was a previously asked question in last 2 years. Which enzyme or which process is responsible for the peripheral conversion of T4 to T3? T4 to T3 is done by your deiodinase enzyme. deiodinase enzyme. Okay, peripheral deiodination is inhibited by which drug? That is used in your hyperthyroidism, that is your propranolol. Propranolol inhibits your T4 to T3 conversion. That is why we consider propranolol better than other beta blockers as better than other beta blockers in hypothyroidism, because of it has a special property to stop what is that peripheral deiodination. Okay, then once we understood about this, let's go to the next important concept. Next important concept, that is your melanin related. So melanin is produced in the skin by which cells? Melanocytes. Skin by which cells? Melanocytes. Okay, so producing the melanocytes with these melanocytes are derived from which cells? Called as neural crust cells. So neural crust cell will form other structure. Neural crust cells also responsible for the formation of C cells of the thyroid gland. C cells of the thyroid gland. It is also responsible for the formation of adrenal medulla, and also it is responsible for the formation of melanin. Also responsible for the formation of melanin. So all these substances are formed by what? All these substances, all these cells are formed by what? Neural crust cell, and melanin is produced. So how melanin is produced? Let's understand. We have an amino acid called as tyrosine. This tyrosine undergoes the influence of an enzyme called as tyrosinase. That will give rise to melanin. That will give rise to melanin. Okay, so tyrosinase enzyme is responsible for the formation of your, what is that? Melanin. Okay, so if there is a deficiency of tyrosinase, it will lead to albinism. Means albinism is a condition where there is a depigmentation all over the body. There is a depigmentation all over the body. So there is one more disease called as vitiligo. Okay, so what is vitiligo, sir? Vitiligo is a condition in which what will be there? Patchy depigmentation. Complete body depigmentation. Albinism. Vitiligo is what? Patchy depigmentation. Okay. So I will explain with the help of an image. Let's see. Let's take the image. Here is the image. So can you see these two girls? Don't change your focus on getting attracted towards the girl. Okay, your focus should be on the disease. So we have two patients here. One patient is having, what is that? One patient is having, this patient is having albinism, means complete body depigmentation is there. But in this patient you can notice there is a depigmentation around the eye, there is a depigmentation around the mouth, there is a depigmentation around the ear. So only patchy depigmentation is there. She is suffering from vitiligo. What is that? Vitiligo. So this can be due to what? Vitiligo can be due to failure of migration of neural crust cells. Neural crust cells. Neural crust cells. So neural crust cells did not distribute all over the body properly. That is one possibility. And one more is due to autoimmune destruction of melanocyte leads to vitiligo. If deficiency of tyrosinase is there, that will lead to disease called as albinism. Both of them are very, very important. Both of them are very, very important. Let's understand the synthesis of catecholamines. So synthesis of catecholamines, you have your phenylalanine. Phenylalanine get converted into tyrosine. Phenylalanine will get converted into tyrosine. Okay, so the tyrosine will undergo hydroxylation. Hydroxylation means addition of OH group will give rise to something called as dihydroxyphenylalanine. This dihydroxyphenylalanine, that is only your DOPA, under the influence of one enzyme called as DOPA decarboxylase. This DOPA will get converted into dopamine. This dopamine undergoes hydroxylation once again to give rise to noradrenaline. Noradrenaline will undergo a reaction called as methylation. What is that? Methylation. Methylation is nothing but addition of a methyl group. Addition of a methyl group. Methyl group is which one? CH3 group. We are adding which group? CH3 group. If we add a CH3, then we will call it as a methylation. So methylation will occur with the help of, what is that? That is with the help of methyl group addition, and this methylation occurs in the adrenal medulla. Adrenal medulla. So in the adrenal medulla, methylation will occur. It will synthesize noradrenaline into adrenaline. So that is the story of your synthesis of catecholamines. Okay. Now catecholamines, when they undergo the metabolism, norepinephrine give rise to some metabolite called as, what is that? Normetanephrine. Okay. Adrenaline will give rise to metanephrine. Okay. Then also they will give rise to homovanillic acid, or also called as, what is that? HMA, homovanillic acid or vinyl mandelic acid. So if at all there is a breakdown of catecholamines, it will give rise to metanephrine and VMA, vinyl mandelic acid. Okay. All right. So these catecholamines, this is the synthesis of catecholamines. Let's talk about the degradation of phenylalanine. What is that? Degradation of phenylalanine. So during the degradation of phenylalanine, I want you to remember only one important aspect. What is that? So that is it forms a compound. So phenylalanine gets converted into tyrosine to 4-hydroxy phenyl pyruvate gets converted into homogenticate. Phenyl pyruvate will get converted into homogenticate. So this homogenticate under the influence of an enzyme called as homogenticate oxidase, it will get converted into mallyl acetoacetate. From there fumarate and acetoacetate will form. So what exactly we need to understand, there is a deficiency of homogenticate. Deficiency of which enzyme? Homogenticate oxidase. If there is a deficiency of homogenticate oxidase, now there is an increase of homogenticate. If there is an increase of homogenticate, automatically it enters into the urine. If enters into the urine, so this urine when exposed to air, it will turn into black color urine. When it is urine exposed to air, it will turn into black color urine. So that this is only called as alkaptonuria. What is that called as? Alkaptonuria. Okay, alkaptonuria is due to deficiency of which enzyme? Homogenticate oxidase. Now this homogenticate, my dear student, it will accumulate in the tissues also, in the body also it can accumulate. It will accumulate in the tissues leading to what? It will accumulate in the tissues leading to joint defects. Leading to what is that? Joint defects. Okay, it will cause achronosis. This is abnormal pigmentation called as achronosis will occur, and also there is a black colored urine when exposed to air. So this is a classic symptom of which disease, sir? Yes, classic symptom of alkaptonuria. So they'll ask you which enzyme deficiency? Homogenticate oxidase deficiency. So once we understood about this, let's understand about the other important amino acid. One is let's talk about your tryptophan. Tryptophan is an amino acid, my dear student. It is responsible for produces water. Tryptophan produce important aspect. This is very, very commonly asked. It will produce something called as serotonin. Okay. And your tryptophan also produces your melatonin. Melatonin related questions are frequently asked. Okay. Melatonin related questions are frequently asked. Melatonin is responsible for the maintain the sleep-wake cycle in the body. So melatonin will do what? Sleep-wake cycle maintenance in the body. So if at all there is a defect of sleep-wake cycle, then what will be the treatment we are going to use? My dear students, we use one drug called as Ramelton. What is that? Ramelton. Okay. So what is this Ramelton? It is an analog of melatonin. Which is previously asked. Which drug is used for the treatment of sleep-wake cycle maintenance? That is your Ramelton is used. Which drug is used? Ramelton is used. Which drug? Ramelton. There is one more drug called as tosimelton. So it is used in the sleep-wake cycle, sleep-wake cycle defect in which group of patient? Defect in blind people. In the blind people, we use sleep-wake cycle defect is there. That is tosimelton. If not, we are going to use Ramelton. So this is the story of your tosimelton, Ramelton, and tryptophan and its derivatives. So tryptophan's one more most important derivative. Tryptophan produces a important vitamin called as niacin. That is your vitamin B3. Vitamin B3 is also produced by which one? Tryptophan. That is your tryptophan. Okay. Let's talk about the tryptophan. So tryptophan deficiency. There is a deficiency of tryptophan is called deficiency leads to a disease called as Hartnupp's disease. What is that? Hartnupp's disease. Which disease? Hartnupp's disease. Hartnupp's disease. So this is the story of your what is that tryptophan. This is the story of your what is that tryptophan. Okay. So once we understood about the tryptophan, my dear students, let's talk about the next important points. What is the next important point? That is your sulfur containing amino acid metabolism. One second, there is this got hanged. Let me solve the problem. Okay. So let's continue. So what we have, Hartnupp's disease. Okay. Then once we understood about that, I want to discuss about sulfur containing amino acids. Sulfur containing amino acid. Sulfur containing amino acid metabolism. So sulfur containing amino acid metabolism. Let's understand, my dear students. Sulfur containing amino acid. So we have our reaction which is occurring. Noradrenaline is getting converted into adrenaline. Is getting converted into adrenaline. By the addition of which group, sir? By the addition of methyl group. By the addition of methyl. So this methyl groups comes from where? This methyl group comes from SAM called as adenosyl methionine. S adenosyl methionine donates the methyl group, and after donating the methyl group, it becomes into something called as SAH. S-adenosyl homocysteine. S-adenosyl homocysteine. Basically, methionine got converted into homocysteine after removal of which group? After removal of methyl group. So basically, what is methionine? Methionine minus methyl group. If you remove a methyl group, that is equal to what? Homocysteine. That is equal to homocysteine. For example, you take a homocysteine and add a CH3 group. Add a CH3 group. That means it is automatically it is methionine. So difference between what is that methionine and homocysteine is one methyl group. That's it. Okay. Now this S-adenosyl homocysteine, whatever is there, it will get converted into homocysteine. All right, this homocysteine will get converted into methionine. What is that? Methionine. So for this methionine, we need to add a methyl group. Automatically it will become into what is that? So homocysteine plus a methyl group means methionine. So this methyl group comes from your vitamin B9. Vitamin B9. So B9 is responsible for the donation of the methyl group to the homocysteine so that it can become methionine. This methionine can be used once again. Now from the B9, methyl group is added to what? Homocysteine. We require an enzyme called as methyl transferase. Which enzyme? Methyl transferase is required. Now for this enzyme methyl transferase to work, we require vitamin B12. Okay, vitamin B12 is required for the action of methyl transferase, and methyl group is donation is coming from a group that is your vitamin B9. Okay, so now what happens? Let's see. So if there is a deficiency of B9 deficiency. If deficiency of B9 is there, automatically what will happen? Let's see. So here I have what is that? B9. B9 is giving which group? Methyl group. So if B9 is not there, automatically no methyl group. So that will lead to what? Homocysteine will not get converted into methionine. So homocysteine level in the blood will rise. So that is only called as the deficiency of B9 will lead to increase of homocysteine. Increase of homocysteine. But in the B12 deficiency means what will happen? This enzyme will not work. Which one? Methyl transfer. If enzyme is also not working, that means homocysteine will not get converted into methionine. So if there is no conversion in B12 deficiency, also what will I be able to find, sir? Increase of homocysteine. Sir, if they give increase of homocysteine, how do we find out whether it is B9 or B12 deficiency? Because both of them have a megaloblastic anemia. So how do we differentiate? So to differentiate for the increase between the B9 and B12 difference, B9 and B12, we will have what is that? We will have to check for one more thing called as methyl malanoic acid level. What you are going to check for, sir? Methyl malanoic acid. Methyl malanoic acid. So methyl malanoic acid, if both are elevated, that is B12 deficiency. If only one is elevated, that is your B9 deficiency. That is your B9 deficiency. All right. All right. So these are the some important aspects related to amino acid. Once we understood aspects related to amino acid, let's quickly recall about one important concept, that is only your vitamins, my dear students. In the vitamins, they will ask you people about diagnosis and deficiency. So functions, all of you have read. So which vitamin deficiency causes which diseases, very very important. Let's start off with the fat soluble vitamins, that is your vitamin A. Vitamin A, just quickly I will tell you, vitamin is responsible for, vitamin A is responsible for vision. Point number one, it is responsible for mucosal healing. It is also a antioxidant. So vitamin A deficiency leads to which disorder? Deficiency, vitamin deficiencies. Okay, vitamin A deficiency leads to what is that? Xerosis in the eye. Xerosis in the eye, the main complaint is xerosis. So we have stages, that is a corneal stage. Okay, we have, for example, retinal stage, we have this thing. So basically xerosis and night blindness, like xerosis and night blindness. And also we get to see one spot called as bitot spot. Which spot? Bitot spot in the eye. So earlier time bitot spot ka image de deta. He used to take you the image and he used to ask what is this. We used to tell bitot spot. Nowadays you will ask bitot spot is made out of what? Okay, so bitot spot is basically a hyperkeratotic spot. Hyperkeratotic spot. This is a very very important point. So remember, hyperkeratotic spot, excessive keratin will be there in the bitot spot. Okay, let's go to the next one. Vitamin D. Vitamin D, my dear students, deficiency in children. In children, it will lead to which disease? In the children, it leads to a disease called as rickets. Okay, in the adult, it lead to a disease called as osteomalacia. Which disease? Osteomalacia. Now osteomalacia is the condition where you can find something called as pseudo fracture on the x-ray. Pseudo fracture on the x-ray, which is also called as, some zone name is there, called as loser zone. So loser zones on the x-ray is a sign of which disease? Osteomalacia. That is due to deficiency of which enzyme? That is due to which vitamin? Vitamin D. So in the rickets in the children, it will cause the defects such as the genu varum or genu valgum, slow closure of fontanelles, rachetic rosary. Then there is a defect of the bone development. Then you have your vitamin K. So vitamin K, my dear students, it is responsible for produces two factors. Produces clotting factor. Produce our synthesis of factor number 2, 7, 9, 10 clotting factors. 2, 7, 9, 10 clotting factors are produced by your, what is that? But that is your vitamin K. So vitamin K is responsible for coagulant. Vitamin K is a coagulant. It causes the blood clots to form. It causes the clotting of the blood. And most importantly, this vitamin K, whatever is there, this vitamin K deficiency leads to, especially in the newborn, leads to hemorrhagic disease of the newborn. That is why, to prevent this hemorrhagic disease of the newborn, so to prevent this disease of the newborn, so to prevent this, we give, for every newborn child, we give what drug? Vitamin K intramuscularly as a form of injection. Then we have, what is that? Vitamin E. Vitamin E is a type of which substance? It is the most potent antioxidant. Vitamin E is also called as tocopherol. Okay, so it is the most potent antioxidant vitamin. Most potent antioxidant among all the vitamins is your vitamin E. Okay, so vitamin E is a potent antioxidant. It has some clinically used. So of course off-label uses like applying for the face, hair, that and all, you people, all of you aware, but also used in NASH, non-alcoholic steatohepatitis, also used in non-alcoholic steatohepatitis. Let's go to the water soluble vitamins. So I'm going to talk only about the diseases caused by the deficiency. Vitamin B1 is also called as thiamine. Okay, it will lead to two diseases. Deficiency leads to beriberi. And if it is in the alcoholic patient, it will lead to Wernicke's encephalopathy. Wernicke's encephalopathy. Okay, these are the diseases caused by your deficiency of B1. So it will have we have a symptoms of this one, that is your global confusion, ophthalmoplegia, and along with that our patient will have loss of balance called as ataxia. So it can be remembered with a mnemonic GOA. So these are the symptoms of Wernicke's encephalopathy. Beriberi can be of two types. One is a dry beriberi and one more is wet beriberi. So what is this wet beriberi does? In the wet beriberi, there is an involvement of cardiovascular system, having a edema, etc., etc. Due to involvement of the cardiovascular system, we call it as a beriberi. Okay. Then B2. What is that? B2. B2 is also called as riboflavin. Riboflavin deficiency leads to something called as angular stomatitis. Which is also called as chiliosis. Okay, what is that? Chiliosis. So basically, this is the angles of the mouth. Here will be the inflammation called as chiliosis. Then you have your B3. B3 is also called as niacin. Deficiency leads to pellagra. So pellagra is the disease associated with 4Ds. Which are 4Ds? Dermatitis, dementia, diarrhea, and death of the patient. And in this patient only, you can find something called as Casal necklace. What is that called as? Casal necklace. Okay. What is that? Casal necklace. What is Casal necklace? So around the neck, there is a inflammation which will occur. So and leading to a necklace-like appearance. Okay. So that is only called as Casal necklace. Okay. So let me show you a picture of the Casal necklace. So I'm just opening the image. So this is a classic Casal necklace. You can find out classic Casal necklace. Here we have, look at this. We found the image. So here we can have a patient who is having a Casal necklace. This is very frequently asked question. Last time also in the exam they had asked which vitamin deficiency and which amino acid deficiency. Of course, I told you people, tryptophan is responsible for the production of niacin. If tryptophan is not there, also same symptoms will rise. Okay. Then you have your B5. B5 is also called as pantothenic acid. So this pantothenic acid deficiency leads to a disease called as burning foot syndrome. What is that? Burning foot syndrome. Okay. So burning foot syndrome is also called as, there is one more name for the burning foot syndrome called as Gresham-Gopalan syndrome. Okay, Gresham-Gopalan syndrome. Then we have vitamin B6. Vitamin B6 is also called as pyridoxine. So this pyridoxine, both deficiency and excess, both of them cause the same clinical feature, peripheral neuropathy. So both of them will cause the same symptoms such as peripheral neuropathy. The patient can have one thing called as anemia. Anemia can be of megaloblastic type. Okay, patient can have anemia. Apart from anemia and peripheral neuropathy, patient can have other central nervous systems and irritation, etc. are possible. Now, what are the causes for deficiency caused due to what? Deficiency is caused due to is a very, very important question. What causes deficiency of B6? Your anti-tubercular drug, that is your INH, called as isoniazid, and also it can be seen with alcoholics. Then you have your B7, which is also called as biotin. So biotin deficiency leads to hair fall. That is why hair fall can occur due to deficiency of which vitamin? B7. Now, B7 deficiency will not occur simply. This B7 deficiency is seen with the people who is having a raw egg intake. Habit of which intake? Raw egg intake. Because raw eggs consist of a chemical called as avidin. This avidin causes the decrease of B7 leading to hair fall. Let's go to the next one. That is your B9. Is also called as folic acid. Is also called as folic acid. Now, folic acid, my dear students, this folic acid is folic acid, whatever is there. This folic acid is responsible for what? Responsible for the development of your brain and the spinal cord, and also it is responsible for your what is that? Development of your red blood cell. So, folic acid deficiency leads to megaloblastic anemia. Megaloblastic anemia. Okay, if folic acid deficiency, if during the pregnancy, definitely brain and spinal cord will be not developed, leading to neural tube defects. Leading to which defects? Neural tube defects. Then we have your B12. B12 is also called as cyanocobalamin. Cyanocobalamin. So cyanocobalamin is also responsible for the formation of myelin. Myelin is the covering which is around your nerves. So now myelin will not be synthesized. Myelin synthesis requires what is that? B12. So if B12 deficiency is there, that will lead to symptoms such as ataxia, loss of balance. Patient can have peripheral neuropathy, inflammation of the tongue papillae called as glossitis. Patient can also have glossitis, and of course he will also have megaloblastic anemia. Megaloblastic anemia. So to differentiate between the B9 and B12, we have two differences. We can use homocysteine and methylmalonic acid, and one more we can look is megaloblastic anemia, whether it is associated with CNS symptoms or nervous system symptom. Then it is a deficiency of what is that? Cobalamin. Okay, last but not the least, vitamin C. Vitamin C is also called as ascorbic acid. It is responsible for post-translational modification of collagen. Means collagen after it is synthesis. See, protein synthesis, whenever it takes place, there is a translation. So after that translation, protein folding or adding of something will occur, right? That is only called as post-translational modification. So vitamin C does that modification on the collagen. So vitamin C deficiency, if it is there, ascorbic acid is the other name. If there is a deficiency, it leads to a disease called as scurvy. Okay, whenever patient has a scurvy, everyone remembers only one clinical feature as a gum bleeding. No, there is not just gum bleeding. There are other clinical features. Delay healing, very slow healing of the wounds. Then child will also have, there is a rashes in the skin. Actually, these rashes are due to what? Small bleeding into the skin, small hemorrhages into the skin, which has a rashes. Then there is a gum swelling and gum bleeding. In the gum, there will be swelling, and also there will be bleeding. Bleeding is possible. Then apart from that, is there any other clinical features for this patient? Rashes, gum swelling, gum bleeding, delayed wound healing, and also that the children can have small bone development defect. That is bone defects also possible. So whenever you are answering a question, look for all the symptoms only, then select the vitamin which is causing what. Okay. So this is the story of what is that? Story of biochemistry, in which I have told all the important points which are covered and which are frequently asked in these topics only. So if you take a major chunk of biochem question, in that 70%, 60 to 70% of the questions will remain in these three chapters only. Major chunk always remains in these three chapters only. That is why I have chosen these major topics to discuss for the quick revision of biochemistry. And sir, with these 2 hours, how many questions we can expect? At least I can guaranteely say 5 to 7 questions possible. 5 to 7 questions in the 2 hours, definitely I can guarantee. 5 to 7. Okay. So this is the story of your biochemistry. Hope your preparation is going on very well. All the very best. अच्छे से पढ़ाई करो. Okay. If you need any help, you can always contact us. Okay, you can always contact us. People know how to contact us. You can contact us through our Telegram, or you can contact us through our Meduhub app. Okay, so this is the story of your, what is that story of your biochemistry quick revision. Thank you so much, bacho. Thank you so much. Bye bye.